Aloha and welcome to Queen's Free Speaking of Health lecture series. Tonight's lecture is called How to Catch a Cancer, Colon Screening and Prevention. My name is Lisa Sakia. I'm with the Queen's Health Systems, and on behalf of Queen's, I welcome you all this evening. It is now my pleasure and honor to introduce you to our main speaker for this evening, Dr. Tracy Murakami. Let's give her a warm welcome. She is a gastroenterologist at the Queen's Medical Center. She received her Bachelor's of Science in Psychobiology and graduated magna cum laude at the University of Southern California. She earned her medical degree at John A. Burns School of Medicine. She did her internal medicine residency at Santa Clara Valley Medical Center and Stanford University Medical Center, where she was nominated by the students for outstanding contribution to medical student teaching. She did her gastroenterology fellowship at the University of Arizona Medical Center. She received a certificate in clinical and translational research in epidemiology and biostatistics from the University of Arizona Mel and Enid Zuckerman College of Public Health. Here is Dr. Tracy Murakami.
Hello and good evening. Today I'd like to talk to you all about how to catch cancer, colon screening and prevention. So what is the colon and what does it do? Well, the colon serves a very important function. It functions to absorb water, and there's also billions of bacteria in the colon that break down the remaining material and food. Then the colon moves the leftover material to the rectum, and the rectum serves as a storage holder for this waste, and muscles in the rectum move the stool out of the body through the anus. What are some of the threats to the colon? There's a lot of things that can happen to the colon. For one thing, the colon can become inflamed by infections or because of decreased blood flow to the colon, so that's called ischemia. The colon can bleed if it develops ulcers in the colon or inflammation in the colon. The colon can also develop pockets or diverticulosis in the colon, which is caused by weakened areas of the colon wall, and those pockets can sometimes get stool stuck inside of them and become inflamed, and that's called diverticulitis. The colon can also develop diarrhea if there's a problem with the water absorption and there's too much water in the colon, and that can cause diarrhea. Inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, can also affect the colon, and those are two different autoimmune disease processes that can affect the colon. The colon can also develop polyps and colon cancer. So what is the difference between colon cancer and colorectal cancer? Well, colon cancer refers to cancers of the colon itself. Colorectal cancer refers to both cancers of the colon and the rectum combined. The reason why they make a distinction between colon cancer and rectal cancer is that rectal cancer tends to be more vascular. And because of the area that the rectum is in, it's close to many structures such as the prostate and other organs. And there is a higher risk of spread to the nearby structures. And so usually the treatment for rectal cancer includes chemotherapy and radiation, whereas the treatment for colon cancer is usually surgery. But for rectal cancer, usually they use both surgery and also chemotherapy and radiation. Now the colon itself is about 5 to 6 feet in length. The rectum itself is the last 5 inches of the colon. So what is colon cancer? So colon cancer begins as small, non-cancerous or benign clumps of cells called polyps. And over time, some of these polyps can become colon cancer, but not all polyps are precancerous, and I'll go into that a little bit later. What causes colorectal cancer? Well, it's caused by changes or mutations in the DNA inside our cells that control the growth of cells and division of cells. And these genetic mutations can be acquired and such that they happen during a person's lifetime and not necessarily passed on to your children. And some of these DNA mutations can be passed on in families, and these are called inherited mutations. And there's some familial inherited syndromes that we know are associated with colon cancer. For example, familial adenomatous polyposis and Lynch syndrome. So what are some risk factors associated with colorectal cancer? So we know that obesity is associated with polyp formation and therefore associated with a higher risk of colon cancer. Physical inactivity and type 2 diabetes, personal history of polyps, colon polyps, or radiation to the abdomen is also associated with a higher risk of colon cancer. Diets high in red meat or processed meats. Diets low in fruits, vegetables, and whole grain fiber. Smoking and alcohol use are associated with other types of cancers as well as with colorectal cancer. And advanced age is also associated with development of colon cancer. So why do we remove colon polyps, or why is this important? It's important because polyps are growth that may turn into colon cancer over time. Now, polyps grow very slowly. It takes about 6 years for a polyp to double in size. So not every polyp, as I mentioned before, will turn into cancer. There's many, many different types of polyps. So we have inflammatory polyps, which form in reaction to inflammation of the colon wall. These are benign polyps. So inflammatory polyps have no potential to turn into cancer. We have hyperplastic polyps, which are very common and usually very small and often located in the rectum or on the left side of the colon. These polyps also have very low to no risk for turning into cancer. And I tell patients kind of think of these hyperplastic polyps as almost like skin tags in the colon. We have tubular adenomas or adenomatous polyps, which are also one of the more common types of polyps that we find in the colon, and they do carry an increased risk of developing into cancer that also increases with the size of the polyp. There's villus adenomas or tubulovillus adenomas, which are higher risk polyps to become cancer, especially if they grow to a larger size. We also have serrated polyps, which are often located on the right side of the colon, so sort of near where the colon begins, where it attaches to the small intestine. And they're often very easy to miss because they're covered by mucus, usually in the colon, and they're often kind of more a flat shape. And these serrated polyps are also considered to be precancerous as well. So if you had to choose which polyp was precancerous, could you tell based on just looking at it? So as I mentioned earlier, over 95% of all the colon polyps are either hyperplastic, which if you remember has pretty much no potential to turn into cancer, or adenomatous polyps, which have a higher risk for turning into cancer. So how many of you guys think that the polyp to your left is a precancerous polyp? Raise your hand. Yeah, on the left, okay. What about the polyp on the right? How many guys? Okay, a little bit more people, yeah. And so, yes, so the polyp actually on the right is the adenomatous polyp. But as you can see, it can be kind of difficult to tell based on just looking at it. And so how do we remove polyps in the colon? So there's different ways and different tools that we have that we can use to remove polyps. We have forceps, which can grab the tissue to remove the polyp, and we also have snares, which are like lassos. Basically, you lasso the polyp and you can burn it off or cut it off. And you don't feel this. You actually have no pain receptors in your colon, so you wouldn't feel any of this. But this is how we can remove them and prevent them from growing further in the colon. And this is also why it's very important that you do a very good job with cleaning out the colon of stool so that we can find and detect these polyps easier. The other thing to note is that when you do a colonoscopy, you want to make sure that the physician doing your colonoscopy spends enough time looking in your colon. And what I mean by that is when they're withdrawing the colonoscope, the camera in the colon, that they're taking time to look and wash the stool away and make sure they're doing a very good job looking for these polyps. And the standard of care is 6 minutes. 6 minutes when you're withdrawing the camera and looking for these polyps in the colon. The other thing to note is that you want to make sure that the person you go to has a high adenoma detection rate. And what I mean by that is that for all the women that are undergoing a first-time screening colonoscopy, that they are finding adenomatous polyps in 15% of all the women who come to them for screening colonoscopies. And for men, this number should be 25%. So 25% of all men undergoing first-time screening colonoscopies, we should be finding polyps, precancerous polyps in them. So March is Colorectal Cancer Awareness Month, and that's why we're doing this talk today. How common is colon cancer? It's actually pretty common. It's the second leading cause of cancer-related deaths in the United States for both men and women combined. It's the third leading cause of cancer-related deaths when you take men and women separately. Nationally, it's expected that colon cancer will cause 51,000 deaths this year, and your lifetime risk of developing colon cancer is about 1 in 24. How many of you guys out there know someone affected with colon cancer? Raise your hands. Yeah, so right, it's pretty common. It's the fourth most common cause of cancer overall in the United States. And the thing is that this is preventable. Colon cancer is preventable by screening. And so I'll talk about that. When we talk about Hawaii, how common is colon cancer in Hawaii? There's expected to be about 620 new cases this year and 230 deaths from colon cancer this year in Hawaii. And that statistics are from the American Cancer Society. So there are many famous people who have been diagnosed with colon cancer or who have died from colon cancer, and you might recognize, some of these names. It was actually Katie Couric went on the Today Show about 19 years ago and had her colonoscopy televised on live TV, and I think that brought about a lot of awareness because her husband actually passed away of colon cancer at age 42, so he was very young, and so she wanted to promote colon cancer screening, and you can actually go on YouTube and find her having her colonoscopy, which is actually a really good video if you have a chance to watch that. So we are finding that colon cancer is rising in younger people. And this is new research. This just came out in a paper last year. But the deaths from colon cancer among people younger than age 55 have increased 1% per year from 2007 to 2016. So those born in 1990 have double the risk of colon cancer and quadruple the risk of rectal cancer compared to those who were born around 1950 when the risk was the lowest. And so we don't know why this is, but there's a couple theories about why this may be. One of the theories is the obesity epidemic. So between 2013 and 2016, more than 1 in 3 American adults consumed fast food on any given day. So 40% of Americans eat fast food on any given day. So this is something that could be contributing to the rise in colon cancer, especially in younger people. When should you get screened for colon cancer? So if you are at average risk, so if you have no family history of colon cancer, if you have no symptoms, beginning at age 45 rather than age 50 is the new recommendation from the American Cancer Society. They just made this recommendation last year. Unfortunately, a lot of our insurance companies are not following suit. So the U.S. Preventative Services Task Force recommends that everyone between age 50 to 75 be screened for colon cancer. So The insurance companies are going by that recommendation. They haven't yet lowered what they will cover for patients, but the recommendation from the American Cancer Society is to begin screening at age 45 based on the research that showed that younger people are more at risk for developing colon cancer. So between the ages of 76 to 85 years old, the recommendation is that you should talk to your physician about your individual risk versus benefit of continued screening tests. And if you are over age 85 years old, it's probably not a good idea to continue screening just based on the higher risk with continued procedures. Why should you get screened? So screening is the process of looking for cancer in healthy people who have no symptoms. 1 in 3 people currently are not up to date with their screening, and we know that screening can help prevent colon cancer, and 60% of colon cancer-related deaths could be prevented with screening. So the single biggest modifiable risk factor for colon cancer is failure to be screened. It's important to know your family's history as well. 1 in 3 people who develop colon cancer have other family members who have had it, but 5 in 100 people with colon cancer have no family history of colon cancer. And I'll show you a graph here. So as you can see, the risk of colon cancer, if you have a family history, goes up if you have more than 1 first-degree relative. So a first-degree relative is, your mother, father, siblings, or children. So the more first-degree relatives you have with colon cancer, the higher your risk. And if they were diagnosed at a younger age, your risk also rises as well. So who might be at higher than average risk for developing colon cancer? If you have a strong family history, as I mentioned, of colon cancer, or a strong family history of colon polyps. And when I talk about polyps, I'm talking about the adenomatous type of polyps or the precancerous type of polyps. So, if someone tells you, I had a history of polyps, and it's your family member, you want to make sure you ask them what type of polyp, if they know what type of polyp it was, because that can make a difference. Your personal history of colon cancer or personal history of colon polyps also increases your risk. If you have a history of ulcerative colitis or Crohn's disease, you also have a higher risk of developing colon cancer, and that's just because of chronic inflammation in the colon is associated with development of cancer. If you have any of those hereditary colon cancer syndromes, if you are of certain ethnicities, so we know that African Americans and Ashkenazi Jewish people have a higher risk of developing colon cancer. And again, if you have a personal history of getting radiation to the abdomen or pelvis, you have a higher risk of developing cancer as well. So what are some of the symptoms of colon cancer? So it can be as simple as a change in bowel habits, and the change in bowel habits has to last for probably more than a few weeks. So if you're a person who normally has a bowel movement every morning, and then all of a sudden, maybe only having a bowel movement maybe once every 3, once every 4 days or so, then that can be a change in bowel habits, and you might want to get evaluated. The caveat also is that, if you're a regular bowel movement, have a regular bowel movement every day, and then all of a sudden have diarrhea that lasts for more than a few weeks, that's another possible warning symptom, a change in your bowel habits that you should be checked out for. If you have any blood in the stool, blood can look like very dark or black, or can look very red or burgundy color. That can be a warning sign as well. Any kind of abdominal pain or cramping that lasts more for a couple weeks is also a potential warning symptom. If you feel weak or fatigued or are anemic, that's another potential symptom of colon cancer, and as well as unintentional weight loss. There's many different types of screening tests for looking for colon cancer. We have our stool-based tests, which look for signs of cancer in a person's stool, and this is called a Cologuard test. It's a newer test. You might have seen some of the advertisements for. And this test, if you do decide to do this test, is done every 3 years. And the other type of stool-based test looks for blood in the stool. So the blood can be microscopic. Your stool could be brown, and you could have little microscopic traces of blood in the stool, and that's what this test looks for. There's two different types of stool tests that look for blood in the stool. There's a FIT or FIT test, which is more specific for human hemoglobin. And there's the FOBT test or fecal guaiac test, which is less specific for human hemoglobin, human blood. So some of these stool-based tests that look for blood in the stool can have false positives. For example, if you eat red meat, or if you take like aspirin or ibuprofen, that can cause a false positive result. These stool-based tests are popular because they're relatively cheap. They can be done at home. You can mail the cards in. It doesn't require a procedure. You don't have to miss a day of work to do these tests. Other types of screening tests to look for colon cancer include a visual examination, so looking directly at the colon with a colonoscope, and that is done usually every 10 years if you have no polyps. There's also what's called a flexible sigmoidoscopy, which looks at the left half of the colon, and that is done every 5 years if you do that test by itself. Or it's done every 10 years if you do the stool-based test every year in addition to the flexible sigmoidoscopy. The colonoscopy is considered to be the gold standard because it does look at the entire colon versus the sigmoidoscopy. It looks at only half of the colon, and so really you could be missing polyps or lesions that are on the other half of the colon. So somebody kind of likened it to doing a mammogram on only one breast. For example. So the sigmoidoscopy is somewhat appealing to some patients because they don't want to have anesthesia. You don't have to be under sedation to get a sigmoidoscopy. And you only do like an enema. You don't have to drink a full bowel preparation to do the sigmoidoscopy. The colonoscopy, has been proven to decrease mortality from colon cancer, but it does require a procedure. You need somebody to drive you home after the procedure. You usually have to miss a day of work to do the procedure, and it does require a bowel preparation. Another type of visual exam is called the CT colonography, also known as a virtual colonoscopy, and it's done every 5 years if you do that test alone. What it is it's a CT scan that reconfigures images of the colon and can show if there's polyps in the colon this way. It does still require a bowel preparation, so some patients are a little bit displeased because they still have to drink a bowel preparation to do the CT colonography. The other issue with it is that it's exposure to radiation, as well as sometimes it does pick up other things outside the colon that we might not have necessarily picked up. And so sometimes we're not really sure what to do with these extracolonic lesions that are found. And the other issue is that the virtual colonoscopy has not been shown to decrease mortality. And it can also miss very flat or small polyps in the colon. So what is really the best screening test? The best test is the one that gets done. So we really want to encourage you, of course, I'm a little bit biased because I do colonoscopies, but really the best test is the one that gets done. And so we want everybody to get screened, whether it's with a stool test or with a colonoscopy or virtual CT scan. We want everybody to be screened. Colonoscopy, as I mentioned before, is considered to be the gold standard because it does reduce mortality from colon cancer, and it has the highest sensitivity for detection of polyps and colon cancer. If you do choose to be screened with a test other than the colonoscopy, it's important to note that any abnormal result should be followed up with a colonoscopy. For example, if you do the stool test and it comes back positive for blood in the stools, the next step would be to do a colonoscopy to make sure that there's no polyps or cancer in the colon. So I'm going to talk about the bowel preparation because I think that is something that scares people and really kind of prevents people from wanting to do the colonoscopy. It's a lot of fluid to drink in the colon to clean out the stool. The one that's most popularly prescribed is a gallon to drink, 4 liters. But there's also many other different preparations. There is something called Movi Prep, which you drink half the amount, so you drink only 2 liters instead of 4 liters. And there's Prepo Pick, which is also a lower volume bowel preparation. So it's good to ask your doctor, what if you have concerns about being able to drink that much volume. There are other options that might be available to you. We also have what's called a Gatorade prep, where you buy the components to make the bowel prep yourself from the supermarket. So you can get the Miralax and purchase the Gatorade, and you mix the prep yourself. And some patients like that because it's more palatable to them, because they can drink the Gatorade and it doesn't have as much of an aftertaste per se. So there's many different type of bowel preparations out there. The type that we most commonly prescribe is done as a split dose preparation. So you drink half the amount of the prep the night before and half of the amount of the bowel preparation the morning of your procedure. And we found that doing a split dose bowel preparation actually cleans the colon much better and allows for a better visualization. Some other colonoscopy prep tips that I have are to stock up on the soft toilet paper or flushable wet wipes because they're a lot gentler on your bum. Also using things like Vaseline or other skin soothing products may help. Keep your entertainment handy, so you could watch a movie while you're drinking the bowel prep and sitting on the john. That was one of my patients recommended that. It tastes better cold, so definitely try to drink it with ice or keep it in the fridge. You can also add flavoring to your bowel preparation, so you could add orange tang or the Crystal Light lemon flavor to your bowel preparation. And another tip I have is to really cut back on high fiber foods about 2 to 3 days before your colonoscopy. Things like seeds and granola and things like that don't get cleaned out very well and can make it hard for us to visualize polyps and can clog up the colonoscope as well. So if you can try to go on a low residue or a low fiber diet a couple days before the colonoscopy, it helps. What tests are currently not recommended for colon cancer screening? So the barium enema is no longer recommended. A lot of radiologists no longer perform this procedure either. It requires an enema using a barium, and it kind of coats the lining of the large intestine looking for polyps. And so we found that actually the CT colonography is much better sensitivity for detecting polyps than the barium enema, so it's no longer recommended as a screening test. A single specimen guaiac FOBT stool card is also no longer recommended. You should do 3 separate samples on 3 separate days if you're going to be doing the stool FOBT card. If you choose to do the FIT test, the FIT test, that's more sensitive for the human hemoglobin, only 1 sample is required for that. The digital rectal exam also is no longer recommended for colon cancer screening because it doesn't visualize the whole colon. How can you prevent colon cancer? So I tell patients, it's kind of leading a healthy lifestyle, kind of more common sense things, but regular physical activity, maintaining a healthy weight for your height, limiting your intake of high saturated fat foods such as red meats and processed meats. Do not smoke, limit your alcohol intake, and trying to eat a diet more heavy in fruits and vegetables and whole grains. Aspirin may also prevent colorectal cancer. And some studies have shown that aspirin reduces colon cancer risk by 40% and helps prevent the return of adenomatous or advanced polyps. The caveat is that you should have a life expectancy of at least 10 years and not be at increased risk of bleeding. It's actually interesting because it's a little controversial about using low-dose aspirin. I think some new guidelines have come out recently in the cardiovascular world in terms of using baby aspirin as a preventative measure to prevent heart attacks. And so it's a little bit controversial, but I think there is some good evidence that aspirin can, at least for colon cancer, reduce the risk. So I have some diet tips for a healthy colon. You want to try to limit your red meat consumption to 18 ounces per week, which is the equivalent of 5 or 6 small cooked portions of beef, lamb, or pork. The other tip I have is to try to increase your fiber intake. A lot of us probably don't eat as much fiber as we should. So for every 10 grams of fiber consumed, your risk of colon cancer actually is reduced by 10%. And the recommendation for the amount of fiber you should be eating daily is about 25 to 30 grams of fiber a day. We should limit our alcohol intake to no more than 2 standard drinks daily for men and 1 standard alcoholic drink for women. And evidence have shown that plant-based diets and vegetarian-style diets have been linked to a lower risk of colon cancer as well. Other things that may help are calcium. So calcium supplementation has been linked to decrease in colon cancer, as well as taking a multivitamin with folic acid. Some exercise tips to keep your colon healthy. So we found that physical activity can decrease your risk of colon cancer. And the type of physical activity might be important. So I came across this study that looked at high intensity interval exercise training, and that actually reduced colon cancer cell numbers. And what high-intensity interval training is doing an exercise with such intensity that your muscles are actually forming lactic acid. So things like jumping jacks, sprinting, doing burpees, or push-ups, or squats, and having a rest period, a short rest period in between. So that kind of exercise has been found to reduce colon cancer cell numbers, which I thought was very interesting. So I just wanted to end my talk with sort of a personal story. These are my twin boys, Noah and Wyatt. They were born last year, and they're about 7 months old now. But my father-in-law actually was very thankful because he did not think that he was going to be able to see his first grandchildren. And the reason is in 2017, he had blood in his stool, and he had a colonoscopy, and we thought it might just be hemorrhoids, but it was actually found he had colon cancer. And what happened was, because he was on Coumadin, he takes a blood thinner because he has a mechanical heart valve, but because he was on a blood thinner, his primary care physician recommended a CT colonography, a virtual CT scan, as a colon cancer screening method, which he had about maybe 10 years ago, instead of doing a colonoscopy, because it was thought that his risk of bleeding was too great, which is reasonable. But we wonder if maybe the CT scan might not have picked up the polyp, which might have been there, because the sensitivity of the CT scan is not as great as the colonoscopy. So long story short, he had the colonoscopy in 2017, and we found, and he went to surgery because of the cancer. He had 1 lymph node that was positive for colon cancer, underwent chemotherapy, radiation, and is doing much better now. But he gave me the permission to share his story because, he was saying if it could help anyone out there, in terms of getting a colonoscopy, even if you think that you might have a barrier to doing a colonoscopy, we can do colonoscopy on blood thinners like Plavix and Eliquis and things like that. If we are in communication with your cardiologist or your neurologist, it's possible to do the colonoscopy even if you are on certain medications. And so that's the end of my talk today.
Thank you, Dr. Murakami. And now we're going to open the floor up to questions, and she's going to take a seat there. And if you have a question, please raise your hand.
Oh, in a previous surgery, they nicked my intestine. So does that make a colonoscopy more risky because that part might separate the scar or whatever it is?
Yeah, so the question was if you had colon perforation in the past, I guess, is it risky to do a colonoscopy? In terms of surgical adhesions and things like that, we know that women who have had hysterectomies or pelvic surgeries, sometimes it is a little bit harder to do the colonoscopy because of scar tissue and adhesions, but it's not impossible to do. And so we can use things like a pediatric colonoscope, which is smaller, thinner, more flexible, to get around these surgical adhesions. But it shouldn't be a contraindication for you to be able to get a colonoscopy, and it would not increase your risk of getting a colon perforation during the procedure if you had a previous colon perforation. It shouldn't increase your risk.
Okay, thank you.
I was a little bit confused when you mentioned 6 minutes. Was that for the withdrawal? How long does the whole, camera goes in and the thing? So how long does the actual colonoscopy take you generally?
Yes, so the colonoscopy generally takes about half an hour, but everybody's different because some people could have more twistier, colons to get there. But yes, I was talking about more the withdrawal time. So once you reach the end of the colon, how long it takes for them to withdraw the camera. That's when we're really looking for polyps. But in terms of the whole procedure itself, I would say the average is about half an hour to 45 minutes.
Based on your slides, I noticed that the plant-based diets had a low incidence. And my understanding is that a whole foods plant-based diet interrupts the growth of the cancers. And in previous talks, the cardiologists and nephrologists had recommended going vegan at, their conference or workshops, and would going on a whole foods plant-based diet preclude one from growing the cancer if there is a cancer? And I've also talked to a friend of mine who worked in colonoscopy recovery, and she said vegetarians who had polyps, they didn't grow back.
Mm-hmm. I think anecdotally, just from personal experience, it seems like my patients who do follow a plant-based diet, vegetarians or vegans, tend to have less polyps. But I think part of that probably is that, diets like we know that have more processed foods, processed meats, red meats have a higher risk of forming these polyps. So I think, what you said is anecdotally, what I think also we see with patients.
Okay, other questions? Raise your hand. I did hear recently that chicken was one of those meats that actually can cause polyps, or is that true? Is there a particular meat that's worse than others?
I haven't heard about chicken, but
Okay.
In terms of meats, it's more the beef, the red meats that have been associated with colon cancer and colon polyps.
Any other question? Oh, you have one here.
What kinds of risk are there with the colonoscopy procedure? Mm-hmm. And do you have data, numbers, percentages?
Yeah, so there's a risk of bleeding, about 5% risk of bleeding, causing bleeding, risk of infection. The risk of perforation, which I think a lot of people are concerned about, is 1%, about 1%. And usually it's higher if we're removing a polyp or removing a large polyp, then there's a higher risk, obviously, of perforation. There's a risk with the sedation medications that we use. If you're having the procedure with anesthesia, there's risk with anesthesia as well. I think those are the main risks: bleeding, infection, perforation, having reaction to the sedation medications. Yeah.
Okay, thank you. We have a question back here.
Yeah. For the for your colonoscopy, if you have surgery to remove the cancer, what actually is done, is there any other treatment or monitoring that goes on to make sure that where you had the surgery, the thing doesn't come back again, or if you're in remission, and you folks have programs to monitor those things if you have surgery? Thank you.
Yes, we do have monitoring programs. So usually a year after surgery, we will do another colonoscopy and check for any kind of synchronous polyps or to check the surgery site. So we do it in a year. And then based on that exam, we usually bring patients back either in 3 years and then again in 5 years. So we do have a monitoring program that we do. In addition, the cancer doctors usually do imaging scans, like a PET scan to look for cancer cells, or a CT scan to look for any kind of growth outside the colon to make sure it hasn't spread.
Question here?
So during the colonoscopy, does the removal of polyp is done at the same time as the colonoscopy, or it is later to be notified to the patient and then another colonoscopy for removal of polyps?
Yes, so we do the removal of polyps at the same time as the colonoscopy. I think the maybe rare situation might be if a patient is unable to come off of a blood thinning medication, then we might not remove at that time, and we might have to bring them back later when it is safe to take you off the blood thinning medication. But in general, we always remove polyps the same time as we do the colonoscopy. Yeah.
Thank you.
Oh, question on this side?
When a polyp is removed, will that cause a cut, and will the colon heal itself?
So when the polyp is removed, there is some bleeding. The bleeding is usually, I liken it to skinning your knee or skinning your knee. So it's not that much blood, but there's a little bit of bleeding. And usually, like I mentioned in my talk, you wouldn't feel it. There's no, pain receptor in the colon.
Okay, there is a question here.
I noticed that you mentioned the FIT and the FOBT.
Mm-hmm.
Where do you get those from? Is it from your PCP?
Yes, so your PCP will put in the order, and usually you'll have to go to clinical labs or DLS, diagnostic lab services, and they will have the kit.
So you
there.
get the kit,
Mhm.
you do what it says, and then you mail it back?
Correct, yeah. Some places you mail it back, and some labs, I believe, you have to turn it in physically.
Okay, because I had read about something where you can actually check it at home. Is there something like that?
Yes, yeah.
What is that one called?
So those tests that I mentioned, the FIT and the FOBT tests, you can do those at home and bring them back or mail them back in. Yeah, so you could do them at home. Correct, yeah. It takes some time to get the results back, yes. Uh-huh.
Okay, we have another question back there.
If you take off the polyps and cannot cut off all, and have to do, and then after the biopsy, I think it's cancer or pre-cancer. Do you recommend to cut off the whole colon or just by portion? If you recommend, do you recommend to take off the whole colon or just the section?
Oh, yeah. So I think you're talking about if we discover a colon cancer during the colonoscopy, not a colon polyp. Is that correct? Yeah. So if we discover a colon cancer during the colonoscopy, usually we'll have to refer the patient to a surgeon, or refer them to a surgeon and a cancer specialist. And so they can make the determination whether they feel that surgery first is the best option, or sometimes, they'll decide to do radiation first to shrink the tumor. So it just depends on the location of the tumor. And, but usually, in terms of your question, usually we just cut out the section of the colon that is involved with the tumor itself.
Okay, thank you. We have a question here.
Yes. if you find polyps and you remove them, are they checked to see if they are cancerous? Do you do biopsies on them? And two, what are the added risks for old people? You said you don't recommend them for people over 80, 85. What are the added risks for those people?
Mhm. So to answer your first question, so we send all of the polyps to the pathology lab, and they'll look at them under the microscope and determine what kind of polyp they are. And so we get that report, and then we'll call you or send you a letter, with the biopsy results. To answer your second question, so really it's the risk with anesthesia. And with sedation for the colonoscopy, there's higher risk the older you are with getting anesthesia for the procedure. And so, potentially the risks outweigh the benefit because, like I think I mentioned earlier in my talk, the polyp grows very slowly. And so really, the benefit of doing continued screening when you're 85 and you might have a polyp, but really it's going to take many, many years before that polyp ever turns into anything. And so if that kind of makes sense, so really the risks of doing the procedure probably outweigh the benefit of removing the polyp because they do grow very slowly.
Okay, we have another question here.
So where would you go, to a clinic or a hospital, or where would you go to do a colonoscopy? And does insurance cover all of them?
Yeah, so usually we have a center, like an endoscopy center that does these colonoscopy procedures. So they're usually either located near the hospital or in the community. We also do these procedures in the hospital as well. And so there's different locations where you can get a colonoscopy. In terms of whether insurance covers it for screening purposes, yes, for colon cancer screening, they will cover. They should cover it. But, as with anything, there might be, a copay, a small copay or facility fee. So it gets a little tricky, but yes, for screening, it should be covered.
Okay, thank you. Question. Oh, go ahead.
For children who have a parent who's been diagnosed, say at like age 36, stage 4, no known family history, those kids are still minors. What age would you recommend they begin a colonoscopy? Or if they should get one at all until, what age would be appropriate?
Yeah, so that's a good question. So the age really makes a difference. So you mentioned age 36 was her mother. So her children should be screened at 10 years younger than the age of diagnosis of their mom, so probably age 26. That answers the question.
Good question. Other questions? Raise your hand. No other questions? Okay, sorry.
You said we found blood on the stool, and then you recommend colonoscopy. What does it say? Are you trying to look for ulcer or polyps? What means the polyps rupture or what?
Yeah,
What
so
causes the bleeding if there's no ulcers?
correct, yeah. So there's many things that can cause bleeding in the colon. Like I mentioned, it can be something like hemorrhoids. It could be something like a polyp, because sometimes the polyps can bleed, especially if they grow large enough. But the thing that we're really concerned about is cancer, because cancer can also bleed in the colon. And so that would be the reason to do the colonoscopy if you see blood in your stools. It could be, hopefully it's something just like hemorrhoids, but we don't know, right, until we take a look. And so that's why I mentioned if you see blood in the stools, you should have it checked out.
Okay, thank you. We have a question here.
Does a patient have a choice on whether to have general anesthesia or not with a colonoscopy?
Yeah, so it kind of depends on the indication for anesthesia. Some patients qualify for anesthesia based on their medical history, also, on their tolerance. So, some of my patients, if they take a chronic medication for sleep to help them sleep or things like that, they can qualify for anesthesia. If patients are pretty healthy and they don't meet any of the qualifications for getting anesthesia, we can still get anesthesia, but it would potentially mean an out-of-pocket cost for the patient with anesthesia. Yeah. So it just depends on your history.
Okay, thank you. Question here.
When would a child require colonoscopy?
When would a child require colonoscopy? We probably wouldn't do like for screening, on a child for colon cancer unless they had a very high risk for developing colon cancer. But we might do a colonoscopy on a child if they did have bleeding or inflammation in the colon, things like that, trying to rule out certain inflammatory diseases that kids could get or things like that.
Thank you. I have a question back there.
I'm curious, what is the rate of return on the FOBT kits that are going out? Like, are people doing them?
Yeah, that's a good question. Actually, I just saw a recent article about the rate of return after offering $10 for patients to turn in the kit, and actually the rate of return was still quite low, even with that monetary incentive. So I think that's a good point. I don't know the exact number, but I know that it is tough to get patients to turn in the stool cards, even with offering them a monetary incentive. So it is a challenge, I think, to get the test done.
What about like a free pen, maybe?
Yeah.
Thank you.
Okay, one last question. I'll scan slowly so I'm not missing any hands. No? Okay. Yes, thank you, Dr. Murakami, for sharing that with us and for the Q&A period, too. I also want to thank some of the other folks. Val Milstein, our sign language interpreter. Let's give her a hand. And Darlene Sardina, who was out in the lobby when you came in. She had all that great information from the Queen's Cancer Center. She goes to all of these events, and she's always so enthusiastic and energetic about sharing information with you. And it's no surprise that she was our June 2018 Employee of the Month last year, so let's give her a round of applause. And last but not least, the two folks wearing those bright yellow, wonderful looking polo shirts, that's Nicole Bowie and James Liu. Those are our volunteers who help sign people in, spending their Wednesdays with us. Our next Speaking of Health lecture, you might want to sign up a little early for this one. This topic usually gets a lot of response. It's on dementia. It's called Deciphering Dementia, Screening, Diagnosis, and Treatment. Now, should you be worried, say if you misplaced your keys, or you see someone, you're like, oh, it's so, what's his name again? Is it John or Jim or James? And then it turns out it's like Masa or something like that. And is that dementia or just a senior moment? We're hoping on the latter, right? So you're going to learn about dementia with Dr. Gina Fujikami. She is a geriatrician here at the Queen's Medical Center. She's going to talk about dementia. What are the signs? How is it diagnosed? What should you do if you or a loved one has the diagnosis of dementia? What are the treatment options, and what are some tips that can help reduce the risk of dementia? That's going to be Wednesday, April 24th, 2019, 6 to 7 p.m. right here in the Queen's Conference Center. To register, you can call our referral line at 691-7117, or just go to queens.org and click Attend a Class. That's going to do it for us. I want to thank you all for coming this evening. Drive safe and have a wonderful evening. Good night.